Welcome to our first nurse webinar of 2017, Nursing Solutions, Challenges in Medication Adherence. These series showcase the work of nurse scholars who have completed the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation. Today's webinar will feature nurse scholars Shin and two Edmund J. Safra Visiting Nurse Faculty Program host coordinators, Edie Simpson and Joan Gardner. Before we get started, a little bit of housekeeping. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the PDF webpage highlighting this talk, and also on the page you're looking at to the left. Health professionals can earn one free CEU through the American Society of Aging. Participants will receive an email by the end of today with steps on how to collect this continuing education credit. You have just 30 days, which is until April 28th, to collect the free continuing education credit. Next slide, please. Next slide, please. Thank you. All right, and we'll go to the third slide and talk about our objectives. Our objectives for today are to discuss the medication adherence challenges faced by people with Parkinson's disease in the community. We are going to acknowledge the medication adherence challenges in the hospitalized person with Parkinson's disease and discuss examples of successful programs which have been established to assist medication adherence issues. It is my pleasure to introduce Shin, who is an assistant professor at the University of Delaware School of Nursing. She attended the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation in 2013, and she has focused her work in Parkinson's disease on complementary and alternative medicine and medication adherence. She is the author of several articles related to her research interests, and today we'll discuss her research on medication adherence in Parkinson's disease, focusing on the community residing adults. Thank you, Shin.
Thank you, Gwen. Hello, everyone. My name is Shin, and I'm currently working at the University of Delaware. I'm going to talk about medication challenges in the community. I'm thankful to have been funded by the Gerontological Advanced Practice Nurses Association to support my study entitled Challenges and Strategies of Medication Adherence in Parkinson's Disease. The findings of this study were published in Geriatric Nursing in 2015. The purpose of this study was to explore adherence and medication taking behaviors in people with Parkinson's disease in the community. An exploratory, descriptive, qualitative research design was used in the study. The research was approved by the University of Delaware Institutional Review Board. Data were collected between July and October of 2013. This study involved digitally recorded, in-depth, semi-structural interviews with 16 participants with Parkinson's disease and 5 caregivers. Interviews were conducted until informational redundancy was achieved. Content analysis was used to describe the medication-taking behaviors of people with Parkinson's disease. Credibility and conformability of the data were assessed by a nurse researcher who's an expert in qualitative nursing research and Parkinson's disease. Participants of this study were 11 men with Parkinson's disease and 5 women with Parkinson's disease. Their mean age was 68.1 years old. Their mean years of education attainment was 18 years. Participants were diagnosed with Parkinson's disease from 6 months to 14 years prior to the interview. All participants were taking either Sinemet or Levodopa at the time of the interview. Levodopa equivalent dose ranged from 200 milligram to 600 milligram daily. 11 out of 16 participants were additionally taking either other anti-Parkinsonian medications such as Requip, Mirapex, and or Azlect. Findings included challenges of adherence to medication regimens. Sub-themes were medication responses, cost of anti-Parkinsonian medications, and forgetfulness. Strategies of adherence to medication regimens included seeking knowledge about anti-Parkinsonian medications, seeking advice from family and friends, use of devices, and use of reminders. This figure shows strategies used to facilitate medication adherence in people with Parkinson's disease. As mentioned before, seeking knowledge about medication and advice from family and friends were really important here. Reminders such as alarms in cell phones and smartphones and devices such as pill boxes and carriers were utilized. So this slide shows the findings with the quotes. Non-adherence such as skipping a dose and changing timing of a dose were reported. The first participant stated, quote, "These, referring to medicines in the pill box, are skipped because I waited too late, so I couldn't take a double dose 2 hours in, so I had to skip one." Next participant stated, quote, "I take medications maybe an hour before I'm going to go see people and go out to dinner or a movie or whatever it is. If I'm going out to dinner, like last night at 6:30, I didn't take it until about 5:30. The second participant mentioned about he's changing his timing of the dose by himself based on his daily activities. Here, the other challenges associated with medication adherence were cost of PD medications and forgetfulness. Some medications were expensive despite insurance coverage. One participant stated, quote, "I wish they would find a more inexpensive version of that stuff. Oh, $500 and some dollars for 3-month supply." The forgetfulness was another challenge. One participant stated, quote, "Without that alarm clock, I am lost. I took them at 6 o'clock in the morning, and then I did not take them again until like 5 at night. So I missed 2 doses. I had them in my pocket, but I flat out forgot all about them." So here, families and friends were helping participants take medications as prescribed. One participant stated that her husband reminded her about her medications. So she stated, quote, "He will say about sometimes, did you take your meds? He thinks it's more often than I think it is." Another participant stated the benefits of support groups. He stated, "I really think support groups are really beneficial in understanding what the disease is, how it progresses, how it's medicated, and what the side issues are." In order to remember medication dose, participants used various reminders. One participant used an application on his smartphone, quote, "Yes, I have an app on my iPhone. It's exactly what I want. It reminds me and it makes sure I take it because if I don't take it, the color doesn't change. Until I check that I took it, the color doesn't change. So in conclusion, participants have experienced challenges and found strategies regarding adherence to medication regimens on a daily basis. The need for education about medications, such as timing of PD medications, side effects, and adverse reactions, is evident. Nurses may improve the quality of care people with Parkinson's disease receive by providing education and ongoing counseling about PD medication, strategies, and devices to improve adherence to medication regimens and the ability to assess possible challenges such as financial assistance for people with Parkinson's disease. So here are some references cited in the study, and thank you for listening.
Thank you very much, Shin.
Thank you.
We will have an opportunity for questions for you, Shin, at the end. And note that all questions can be submitted by clicking in the text messaging box in the bottom left corner. Type in your question and then hit the send button. That was a very good talk about issues that people in the community face as far as keeping track of their medication timing. But we know also that when people with Parkinson's disease are hospitalized, there are equally important challenges that we must address. We know that Parkinson's patients are hospitalized often, 45 to 50% more times more often than their peers, and we know that it results in a longer hospital stay. Also, a study by Mahajan reported that only 33% of people that were hospitalized with Parkinson's returned directly to their home. Many did need rehabilitation or a nursing home placement afterwards. Since patients are not usually admitted for Parkinson's disease, the attention is diverted to the more present and presenting issues such as a fall or infection or a surgery unrelated to Parkinson's disease. This results in a lot of issues of medication taking difficulty. Next slide, please. For example, many times the wrong formulation is given. This could mean that a controlled release was given instead of an immediate release carbidopa, levodopa, or vice versa. Other issues include drugs not being on the hospital formularies. We've often heard that Stalevo, which is carbidopa, levodopa, and tacopone, is not on all hospital formularies. When drugs are stopped abruptly or not given, or when contraindicated medications are given, 61% of people with Parkinson's disease experience severe complications. Also, we know that when people with Parkinson's disease go into the hospital, 75% of the time their home schedule is not honored. This is a schedule that has been most often carefully titrated on the outpatient basis, and it's the very medication that makes it possible for them to move, talk, speak, swallow, and participate in the care needed for their admitting condition. Nurses can be and should be a change agent in this process. We're now going to hear from two expert nurses who work in Parkinson's disease centers, and they will discuss how they have developed systems to improve the plight of people with Parkinson's disease when they are hospitalized. First, I'd like to introduce Edie Simpson. Edie Simpson is a registered nurse with experience in neurology, research, clinical support, and education. Formerly of the Muhammad Ali Parkinson's Disease Center in Phoenix, Arizona, Edie is the host site coordinator for the Edmund J. Stafford Visiting Nurse Faculty Program at the Parkinson's Disease Foundation at our site in Phoenix. Thank you.
Hi, good morning, everybody. Thank you for having me on the webinar, and I want to tell you a little bit now about our project called It's About Time. And let me be clear, too, that this initiative regarding hospitalization for patients with Parkinson's disease was a collaborative effort between the Muhammad Ali Parkinson Center, the Barrow Neurological Institute, and St. Joseph's Hospital and Medical Center. And the goal of this project was to ensure the safety of people with Parkinson's disease when they were hospitalized by instituting consistent mechanisms to ensure an appropriate and timely delivery of medications based on the at-home schedule and to prevent the administration of contraindicated medications, and also to educate the hospital personnel on Parkinson's disease and the importance of continuing the appropriate treatment of Parkinson's disease while patients are hospitalized, and to support their efforts. But just a little background about how this project evolved. As is the case in many centers that work on this problem, this project came about as a result of a complaint. And the complaint was from the spouse of a gentleman who had passed away in one of our local affiliate hospitals. This gentleman had Parkinson's disease, but as is typical, he was admitted to the hospital not for Parkinson's disease, but for other reasons. And in his case specifically, it was for chest pain, which ultimately was determined not to be of cardiac origin. But unfortunately, 8 days after his hospitalization, he passed away. And his wife related to us that during his hospitalization, this gentleman did not receive Parkinson's medications at all for the entire 8 days. And in addition, he received contraindicated medications. But her biggest complaint was that she was equipped and had with her an Aware and Care kit. Now, for those of you who aren't familiar, the Aware and Care program is one that has been developed by the National Parkinson's Foundation to assist patients for advocating for themselves during hospitalization. And the kit is just a small black bag that has inside a tremendous amount of information that the patients have available to them to share with hospital staff, specifically regarding their needs during hospitalization. Well, this spouse had an Aware and Care kit, so she had felt initially very empowered that she could go to the hospital and share this information with the staff. However, even in spite of the kit, it wasn't enough to have the staff listen. So we thought, well, this is very telling because we're asking patients to advocate for themselves at the most difficult time for them, and that is when they're ill and during a hospitalization, and that the hospital has to take on some accountability for the care of patients with Parkinson's disease and their specific needs. So we went to our director of nursing and talked with her, initially going in thinking we were going to address an intensive educational program with the staff, and she said, yes, that's great, but we have to do something else. So that's when we came up with this plan that would allow us to use the electronic medical record as an educational tool for staff to keep them constantly aware of the needs of patients with Parkinson's disease when they're in the hospital. So what we did was develop a plan using the electronic medical record. It's sort of the way things are today, how things are used. I told them that if we could go back to the Cardex, I would be really happy. But we don't have that sort of central way of doing things anymore. The electronic medical record is the way of the future. So we wanted to develop a plan of using the electronic medical record as an educational tool for staff. We also wanted the pharmacy to assign the critical medication designation to the Parkinson's disease medications. This designation limits and reduces the acceptable range of administration delivery. Typically, it's an hour. This alerts the nurses when the medication is a half hour overdue. Not perfect, but it helps. And then we wanted to develop an educational program for nurses, nurse educators, and hospital personnel and physicians that was ongoing. So the first challenge we had was how do we identify people with Parkinson's disease when they come in the hospital? And the thought was, okay, we put it on the admission form so that people ask directly, do you have Parkinson's disease, yes or no, and that the medical record would respond accordingly. But we were not able to do that, so we had to go back to the drawing board and say, how do we identify people with Parkinson's disease? So the idea was developed that we would trigger these alerts in the electronic medical record based on the Parkinson's medications. Let's go back to this one. The Parkinson's medications, they're not exclusive to Parkinson's disease, but pretty darn close. So we felt like we weren't going to make any major errors. If anything, we would have too many people targeted, but that was okay. So we used the Parkinson's medications as a way of triggering the electronic medical record alerts. So the first thing that happens when a provider or the nurse puts a Parkinson's medication into the medical record on behalf of the patient, this alert will fire, which says that your patient has been identified as taking a medication which is associated with Parkinson's disease or other related movement disorders. And please document the patient's complete home medication schedule and record their precise customized home dosing schedule for this medication, and it tells them where to put that information. And then to contact the pharmacy to coordinate hospital dosing schedules to align with the at-home schedule. Now, these alerts, they had to be somewhat generic because this was not limited to our hospital, but to all hospitals under our corporate heading. So they had to sort of apply universally. The second alert that comes up is for the individual Parkinson's medication. And we did include all the Parkinson's medications, not just carbidopa, levodopa, so that the nurse or the provider will see a notation about this medication, that it's used to treat the symptoms of Parkinson's disease. Please give this medication on time based on the patient's home medication schedule, not on the standard hospital times. And it also says to see the reference text. The reference text in our medical record is a place where there is information stored. And the nurses are actually audited on the amount of time that they access this reference text. So the reference text will stay open when it's clicked, and you will see this information. On the left is just sort of a little table, a little bit about Parkinson's disease, what it's caused by, and the medications that are used to replace it, the importance of adhering to the home medication schedule, and then there's a list of the contraindicated medications as well as their safe alternatives. On the right-hand side is a table of the Parkinson's medications, giving their name, a bit of information regarding administration, with certain things such as, that you can crush carbidopa, levodopa 25-100, but you can't crush the extended release, little tools like that that are addressed there, and then a list of the commonly noted side effects of those medications. So we felt that this was a tool and a reminder for the nursing staff and the physician staff to remind them of the things that hopefully we teach them or that they remember, or we teach them in in-services or that they can recall. So that if they don't remember what that in-service said 6 months ago, but there's some lingering thoughts about it, and then they have a patient with Parkinson's disease come in, there's a way to help them recall that information. So the other thing that will happen is we wanted to hoped for sort of a fail-safe mechanism where everyone in the medication loop was notified that this patient may have Parkinson's disease and is on a medication that requires more regimented administration. So when the medication is put into the medical record, this alert comes up, again, identifying this medication as a medicine that's used to treat Parkinson's disease and should be ordered on the home medication schedule. In addition, the pharmacy receives an alert when this medicine is put into the medical record that there is a patient who is on a Parkinson's medicine. The idea being that if that medication was not ordered on the home medication schedule, that the next person in line who's in charge of formally completing that task, if that's not there, they're reminded to contact the nursing unit or the provider and have them enter that medication on the specific medication schedule. The hope for this was that there was a mechanism in place that there would be fewer mistakes or oversights made. The other alert is triggered when a medication that is contraindicated in Parkinson's disease is added to the medication list in the presence of a Parkinson's disease medication. So if the patient is on carbidopa-levodopa, for example, and the physician attempts to order Phenergan, then this alert, the one you see on the left there, will fire and say that this drug is contraindicated for use in patients who are taking medications associated with Parkinson's disease. Please discontinue this drug and select the safe alternative from the options. So all the physician or ordering provider has to do is click discontinue and check the box for the alternative, the safe alternative. The same applies for the antipsychotics, which you see there on the right. Now, this order can be overridden. However, there has to be a reason identified. So in addition, we started out when the alerts first came live. We started with our first series of nursing in services, which we provide, giving about 4 CEUs to the nurses participating, and we advertise those and target toward nurse educators and charge nurses, with the idea being sort of like trickle-down education. The people who are the more stable staff members, the higher ups, can then share that information in a more ongoing manner with the staff that tends to change more frequently. So this slide is a sort of an arithmetic representation of what we've seen so far. We did not, unfortunately, have a reporting system with our electronic medical record that allows us to easily analyze this data. So right now, this is pretty arithmetic. You know, it's adding up all the numbers and looking at them in very simplistic terms. Fortunately, as of January 2017, we now have a reporting mechanism that will allow us to do a much more statistical analysis. But I'm encouraged by this slide just because even with the simplistic way that we've looked at this data so far, we're seeing trends in the right direction. So the home medication schedule on the bottom, you can see we looked at this information 6 months before the alerts went live and our first nursing in services, and 6 months after. And you can see in the red that there has been an improvement in the documentation of the home medication schedule. And honestly, anecdotally, in looking at thousands of these records, anecdotally, it's much better than it used to be. Also, doses that were administered within a 15-minute plus or minus window, which is our ideal window, also improved. The doses within a 30-minute range improved, and the doses that were administered greater than 30 minutes, which is obviously much too long, decreased. So I think even though it's not as dramatic as we certainly would have liked to have seen, I think we're on the right path, and I think once we are able to look at this data statistically, we're going to see what we want to see, and that is improvement in all of these areas. So our future objectives are to continue staff education. We offer these in-services every 6 months. We're going to add the hospitalists and obviously the emergency room, where in our case really needs to be looked at on an individual basis to see what we can do to improve care for Parkinson's patients there, but to include the key hospitalists, which we saw as an important piece. We're now going back full circle and coming back to how do we educate patients about hospitalization, not only with the Aware and Care Kit, but how can we make the Aware and Care Kit more effective, and how can we share with patients the challenges that hospital staff face and have them partner and feel more in partnership with the hospital staff to achieve their goals and not be in conflict with them. So obviously our goals remain to improve timely medication delivery and the use of the at-home schedule in the hospitalized patient with Parkinson's disease. And now I'm going to turn this over back to Gwen.
Good afternoon, everybody. I'm Joan Gardner. I am a nurse from the Struthers Parkinson Center in Minneapolis. And this project, as Edie's, was a collaborative effort between the Struthers Parkinson Center, which is a center of excellence of the National Parkinson Foundation, and Methodist Hospital. It's our hospital, and it's associated with the COE located in St. Louis Park, Minnesota. So the Hospital Pills on Time project at Struthers really began in 2011 when, as Edie pointed out, this Aware and Care toolkit, which was developed by the National Parkinson Foundation. They were developed and distributed to centers and chapters. And at that time, we began giving the kits out to our clinic patients and families and to those who attended our area support groups. So then in 2013, I received a call from the clinical nurse specialist from the neuro and general medicine floors at Methodist Hospital. And she contacted me about partnering regarding Parkinson's education for hospital staff. Her call to me was prompted by a patient complaint, which caught her ear, and also the ear of the hospital pharmacy director, so very similar to Edie's situation. And the complaint cited misunderstanding of Parkinson's symptoms by hospital staff and also a lack of awareness of the need for Parkinson's pills on time, with a challenge that Parkinson's pills need to be administered in a more timely fashion. Then things kind of didn't have a lot of momentum until 2015, when actually another patient and family complaint was registered, and this complaint reached the ear of the CEO of our organization. The CEO challenged the hospital nursing leaders to find solutions to problems regarding the lack of staff knowledge of Parkinson's symptoms and their medication needs. So it was really with nursing administration support that the fire was really lit, and this resulted in support for the need of Parkinson's education to nurses in the hospital, the monitoring of Levodopa administrative times, and the process of ongoing nursing education. So we used the electronic medical record in really a lot of ways. To start with, the Methodist Hospital clinical nurse specialist worked with nursing informatics at the hospital to gather data for reports at the start of the project, and we still use the EMR throughout this project. In 2013, I was asked to do some nursing in-services at Methodist Hospital, but quite honestly, they were very poorly attended and had poor engagement within the hospital team. And this actually contrasted in 2015, and I really think it's because of nursing administration support of the program. We had more opportunities to do the in-services at various key nursing units within the hospital, and the length of time that was offered to present this information was also increased. So, and we had a lot more nursing engagement at these in-services in 2015. The hospital pharmacists were also really key to the success of this program, and I'll talk a little bit more about that in a couple slides to come. And then also in 2016, we did start an initiative in the Methodist Hospital emergency room. You know, there's always a story behind every new project, and this story involved an ER physician who witnessed a miracle when a patient who could not swallow was given orally disintegrating carbidopa-levodopa and was suddenly able to speak, swallow, and move. So this prevented a workup to rule out a stroke for this patient and prompted a call to our medical director at Struthers, and more to follow about that initiative as well. So this table shows some of the pre-project electronic medical record data that we collected in 2013. Our focus was only on carbidopa-levodopa doses, and you can see in the table that frequently doses were either too early or too late. So in the first data set, the first dose is 30 minutes early and the second dose 30 minutes late. The third dose was 75 minutes late. So the intended 4-hour dose interval between the first and second dose was actually 5 hours, and the intended 6-hour dose interval between the second and third doses was almost 7 hours. So one would conclude that the patient functioning was not as optimal as could have been if the doses were delivered on time. In the second data set, I assume that the nurse or doctor entered TID for the schedule instead of the exact times taken at home. So with no specific times entered, the levodopa schedule automatically converted to the hospital TID schedule, which again, we would assume resulted in poorer functioning of the patient and a lot of anxiety by the family because the hospital pill schedule was not what the patient was used to. The third data set really looks pretty good. In addition, we developed a PD compliance scorecard, and this was with nursing informatics. The scorecard graphs the percentage of levodopa doses delivered within 15 minutes of the scheduled time for each dose of levodopa on each hospital nursing floor. So then monthly, the nurse manager receives a monthly report for their floor and discusses it with nurses on that unit. So it kind of keeps the project alive and in front of hospital nursing team. Again, electronic medical record was huge. Our organization uses Epic for our EMR. And the first EMR intervention that you see on the top was within the medication administration record, the MAR. In this strategy, the overdue button turns red when the dose is 1 minute late. But to see that alert, the nurse has to be logged into that patient's medication record, so is very likely already in the patient room and about to administer the dose before he or she sees it. So this alert really was not very effective, and Epic was not able to give us an alert that occurred before the dose time was due. So in December of 2015, the best practice alert, which you see in the lower part of the screen, was added. This alert was added to the S-bar for each person on levodopa that reads, due to the time-sensitive nature of medication administration to patients with Parkinson's disease, please ensure that all medications are administered within 15 minutes of the due time. Edie talked about if we could go back to the Cardex, it would be very simple. And as I understand it, the S-bar is like the Cardex in the current EMR world for nurses. So this alert had really a big impact on the Pills on Time project. Other things from educational strategies. In 2013, the Struthers Parkinson Center nursing team led nursing grand rounds, which is attended by hospital and ambulatory nurses. The biggest impact for this presentation was we asked some care partners to come and tell their stories about the hospitalization of their loved one. Also, as we began this project in 2013, we used the EMR to gather data regarding what specific floors people with Parkinson's were hospitalized. So this data proved really important as our medical director tried to get Parkinson's disease on the agenda for the hospitalist monthly meeting. Before the proof of data, she was told that people with Parkinson's were not seen very often in our hospital. But in fact, the report showed that 25 to 30 people with Parkinson's are hospitalized each month. So that was a really important part in order to get time in front of the hospitalists. I think it's really exciting that changes have now been made in orientation, and this was really, these efforts were really led by the Hospital Nursing Administration and the hospital educators. So specific PD education is now available to new nurses that enter our system. First of all, a patient story has been added to the nurse residency class about the PD person and their needs about med timing. These nurses in the nurse residency class are nurses who are new to acute care, so either transfers from long-term care or outpatient settings, and the program extends a year from their hire or transfer. So it's not really an orientation, but it's just a program that really assists in their transition. And in 2016, over 100 nurses participated in this program. In addition, a clinical simulation is used in basic inpatient nursing orientation, which occurs in the first week of hospital new nurse orientation, to show time-sensitive meds and PD specifically. And then PD meds are used as a point to be emphasized in the debriefing by the staff. And then third, Parkinson's disease medication timing sensitivity is embedded into the orientation roadmaps for all new hires, which is then signed off as a core competency expectation. So let's circle back to the pharmacy. Again, really engagement by the hospital pharmacy was key, especially to have the director of pharmacy and other pharmacists really involved. So a key intervention was the decision to stock immediate release carbidopa, levodopa on all key floors in the Pyxis units. So this reduced the waiting period between the physician order placement and the nurse access to the medication. And then also, pharmacists receive a report, as you can see in the lower part of your screen, and it's a daily report that lists hospitalized patients who receive levodopa. So from this report, the decentralized pharmacists make rounds, and in the rounds, they check in with families to ensure the hospital PD meds match those from home, and also checks the scheduled versus administered levodopa times, and we'll talk directly to the nursing staff if a discrepancy is found. And then they also have aware and care toolkits available so that they can distribute them to families who do not have one. So this is our exciting graph that really shows the success of our program with achieving levodopa within 15 minutes of the scheduled time. Really a dramatic improvement from 42 to 44% doses in 2012 to 2014 to 66% of doses within the first months and beyond of 2016 that were delivered within 15 minutes of the scheduled time, with a statistically significant p-value of less than 0.001. And you can see in the graph that there also have been improvements in administration of medicines within 30 and 60 minutes of the scheduled time. This graph just shows the data for the Methodist Hospital Emergency Room Project. As I said, that was implemented in June of 2016. Prior to implementation of the program, we worked together with the ER staff. They actually developed nursing education for their emergency room staff, their own alerts within the EMR, and actually a change in the ER flow for patients with Parkinson's disease. So this graph represents numbers of doses of levodopa administered while a patient was in the ER with Parkinson's disease. And you can see that there was an improvement in treatment in the emergency room from 41% to 81%. And this was in the first 3 months of the project. The other really interesting thing was there was a policy change in 2016 that allows Parkinson's patients to self-administer their home medications while in the ER, and that also has really been a great thing for our patients. The other thing that we developed was that with the emergency room and hospital nurse educators, we developed these cards and we provide them to our patients and families to present to the emergency room. Struthers really had a huge aha when working with the emergency room team. Like was said previously, people with Parkinson's don't go to the hospital because of their Parkinson's disease. Usually something else happened. They have an infection, or they fell, or they have a change in level of consciousness, and they don't necessarily say, I fell and I have Parkinson's disease. So we now very intentionally do patient education around their need to let staff in the ER know they have PD, and we develop these cards to kind of help that process. And so it just says, I take my medicines frequently and I don't want to miss a dose. Please order my Parkinson's meds right away so I can take them within 15 minutes of my scheduled time. It's also great that the ER has changed their triage process. So when they see this card, or if a patient or family tells the admission person in the ER that they have Parkinson's, they get the triage nurse in more quickly, and so that the medication reconciliation process can get going sooner, hopefully resulting in quicker administration of the needed PD pill dose. So lastly, there's still work left to be done. When I think about transitions, we know that transitions are a problem throughout all of healthcare for people with Parkinson's for many reasons, especially in terms of medication management and timing of medication doses. So certainly continued education to nurses and hospitalists about entering that specific home schedule within the hospital. So if a patient should go from the cath lab to the cardiac floor, how are those transitions encouraged around PD pill times? And we now tell our people with Parkinson's to call our clinic or schedule a clinic appointment if their PD med schedules were changed during a hospitalization, just so that we can circle back to them and ensure that they're on the right dose and frequency.
Thank you very much, Edie and Joan and Zhushang. All of you have done phenomenal work in the area of medication adherence, both in the community and in the hospital. And we have several calls that have come in. If folks have calls and you haven't called in yet, you may do so by texting, writing in the text message box your question, and then hit the button send on your screen. We have several questions to start with, and Shin, I have one question for you to start with. You mentioned alarm clocks and an iPhone app. Can you tell us a little bit more about devices that some of your patients were using that they found helpful, and where these devices may be available?
Yeah, the most older adults with the Parkinson's, they set the alarm in their handheld cell phones, cellular phones, not the fancy, the iPhone or all those things. So they just set the alarm. So when the alarm goes off, they will take their medication. That's the one thing that I saw. One lady used her own the cell phones. And then the other gentleman, who's really intelligent and retired scientist, he found the apps from some kind of company. I don't think I can say what kind of website was it, but that site provided the apps. And also I think if people with the Parkinson's, if they own a smartphone, they can go to the App Store or the Google Play to find the medication adherence applications. If they like anything, they can use it. So they can enter, I'm taking Cinemed, 9 a.m., 11 a.m., whatever the schedule. It will pop up and it will give the person alarm or some kind of alert so they can take the medication. So that's what I've been seeing. And also the participants are taking their pills in a portable carrier. with their keys, or they will put the pills in their work desk drawer, and some pills in the car, all those things. So they have access whenever they need to take it. That's what I've been observed from my study.
Thank you very much.
Yeah, I hope I answered your question.
Yes, you did. That's very helpful. We have the same question from several folks about making Parkinson's disease a priority in the hospital. And Joan and Edie, you both have done such excellent work in this area. But could you tell us just a little bit about maybe the largest or the biggest hurdle that you had to overcome, or tell us a little bit about how that all came to be?
I think our biggest hurdle was we had a lot of support from nursing administration, but we have a corporate, we're overseen by a corporate entity. And so a lot of the things that we attempted to do had to be approved by any number of committees, and they had to be in compliance with all of the hospitals that were under that corporate head. So some of the verbiage kind of got watered down, if you will, in order to be more acceptable to different hospitals. And we had, the only complaint we had was there was a psychiatric hospital that was affiliated with the corporate entity, and they use a lot of benztropine, which was on the list of Parkinson's medications, but they also use it in concert with Haldol. And so they would get these alerts all the time that wouldn't have let them, order that combination. So we had to overcome some of these things that really, because of the corporate nature of our particular circumstances. But we had absolute full support of our nursing staff and nursing administration, which I think you've seen also in Joan's case is key to the success of any program.
Yeah, I really agree with Edie, and the hurdle that we had actually was prior to the buy-in from nursing administration that this was an important project to become invested in. And once nursing leadership was engaged, we were, given time for in-services. And let's face it, there's lots for nurses to learn and to receive in-servicing on within the hospital setting. And so to give us time seemed to be a huge thing for Parkinson's education. But once nursing leaders were engaged, we met with all kinds of committees, the safety committee, they really engaged us on so many different levels. So for us, the hurdle was not having nursing administration buy-in.
One of the things that I think helped us as well is it's one thing to tell people, okay, nurses are busy. We know that. They have way too many patients to take care of. But we developed a series of videos which are available through the National Parkinson Foundation if anyone wants to use them. We shared them, and the patients were happy to do so, where we videotaped, and these were done under different circumstances, but they apply as well, where we have videotape of patients on their medicines and when they don't have their medicines, often on videos. We have about 8 or 9 a series of videos that illustrate what happens if a patient doesn't have their medications. And that was probably the tool that had the greatest impact on the nurses during our nursing in services, because it's kind of, hard to think, oh, geez, you're asking me to, do more and more, even though we very purposefully tried to make our program not impact on the workflow to any great extent, but to have that visual impact of what we're talking about when we talk about patients wearing off and what that means and the impact it can have on function was really one key element for all the nurses to buy into this as they see these things.
Thank you very much, Edie. How about the issue of medication technologists that are so commonly used in nursing homes and assisted living care facilities? They, I think, in facilities such as those also have the same issues of defaulting to the institutional time, whereby if a patient's medication is 4 times a day, it automatically gets divided up every 6 hours. Have any of our speakers had experience with this audience of nursing home techs in the past or have plans to do so?
Our social worker at the Muhammad Ali Parkinson Center, she developed a program for, if you will, professional caregivers, which we presented and in service to several facilities in the area, and we're hoping to take this as an online program in sort of a similar fashion of educating them, again, using the off-on videos and explaining why this is so important for the function of your patients, and sort of carrying the same theme to those facility types as well.
Yes, and at Struthers, we actually have developed the Struthers Parkinson's Care Network, where we partner with senior residential communities and actually home care agencies as well around Parkinson's education. And so it's really care communities that have made a commitment to improving care for people with Parkinson's disease. And as it's just as Edie described, as you teach nurses or TMAs or CNAs who might be giving Parkinson's medicine in these care communities, you teach them, you show them the off and on videos. They understand why it's so important and understand that people aren't on purpose not moving really well at one time of the day and not at the other. It's because of not having enough Parkinson's pills on board because of ineffective schedules. So it's interesting, the electronic medical record systems at many of the care communities, they are able to put an alarm in the system so that the nurses get an alarm 15 minutes before the dose is due, so they can actually be on time with their pills. And we use visual reminders for them to kind of see which person has Parkinson's, and we ask that they deliver those pills on time, that they're a time critical med, and not just go down sequentially down the hall from room 1 to room 8 in delivering pills at a certain time of the day. So again, it's about education. I don't think any nurse wants to give bad care, but if you don't know, you can't do, and knowledge is really power.
Thank you, Joan. As always, we have more questions than time, but I would like to ask one last question of any of the presenters who would like to respond. One of our listeners would like to know if neuroleptic malignant syndrome is a potential complication of not giving the Parkinson's medication.
It's rare, but yes, it absolutely is.
I would agree with you, Edie, thoroughly. And probably more commonly, we see dopamine withdrawal syndrome, which is very uncomfortable and detrimental to patients, and is really something that we have to be aware of when holding medication.
And it can be with almost any of the Parkinson's medications, the agonists as well, and so again, another important reason why everything needs to be maintained for that patient in the hospital.
Thank you very much. Okay, well, please complete the online survey that you see on your screen. Your feedback is really important to us to help us improve our webinars and make sure that you get the information you need regarding Parkinson's disease. If you're interested in continuing education credit, please watch for the email reminder, which will come later today, and allow up to 60 days to receive your continuing education credits after you apply for them. An archive of today's event will be made available starting next week on Tuesday, April 4th at www.pcc.org. And if you would like to listen to the webinar again or share it with your colleagues, please look for it after Tuesday, April 4th. Our next webinar is scheduled for May 23rd, 2017 at 1 p.m. Eastern Standard Time. The topic for this webinar will focus on genitourinary issues in Parkinson's disease. Thank you again for participating today. And again, we thank the Edmund J. Safra Foundation and the Parkinson's Disease Foundation for making this series possible. Thank you.